Good morning, everybody. I would like to thank for the kind invitation to this meeting here. The data that I'm going to present today, they were supported by an unrestricted grant from PharmaSelect. PharmaSelect is a small Austrian company. I don't think that they are at the UK market, but they have some business in other countries as well, particularly in the Eastern European countries. As you can see from my list of financial disclosures, carotenoid research is not my major interest. It's not my major area of research. I do a lot of research in imaging and in glaucoma. But when I got interested in macular pigment measurement and the story about carotenoids and vitamins in the eye, when I came into the field of spectroscopic OCT. And when I came into the field of spectroscopic OCT, I looked a lot into reflectometry and what was done in this field over the last 20, 30 years. And this is basically how I came into the field in the recent years. Now, the study I'm going to present to you today is a lutein intervention study, Austria, called LISA. And it was published in 2011 in Investigative Ophthalmology and Visual Science. Most of the work was in fact done by Günther Weigert and Semir Akaya, that were two of my PhD students at that time. And the work was done together with the Department of Ophthalmology in Vienna with Ursula Schmidt-Erfurth. Now, the main hypothesis of the study was that a 6-month supplementation increases macular pigment optical density as measured with reflectometry in patients with age-related macular degeneration. This main hypothesis was also the basis for our sample size calculation. We tried to test additional hypotheses, and this was that a 6-month supplementation increases visual acuity in patients with age-related macular degeneration. A 6-month supplementation increases macular function in patients with age-related macular degeneration. To answer this question, we used microperimetry, and I will come back to this a little bit later when I talk about the methods. Then we investigated whether the increase in macular pigment optical density after administration of lutein is dependent on the stage of AMD, and if the increase in macular pigment optical density after administration of lutein is dependent on the baseline value of macular pigment optical density. So these were the hypotheses. This is a little bit about the design of a study. It was a randomized placebo-controlled a parallel group study over 6 months. And the randomization was 2-to-1, lutein versus placebo. And a total of 126 patients with non-exudative AMD were recruited for this study. Recruitment for these patients was not easy because one of the inclusion criteria was that all of the patients did not have a history of food supplements. So none of the patients had taken either lutein or zeaxanthin before, nor any other vitamin or food supplement. The duration of the study was 6 months, and the dosing was as follows. In the months 1 to 3, they got either 20 milligram of free lutein or placebo, and in the months 4 to 6, they got 10 milligram of free lutein or placebo. And patients had 4 visits at baseline, 1, 3, and 6 months. The macular pigment optical density was measured by reflectometry, and this was a custom-built system based on the work that has previously been done in Maastricht. This was the main outcome variable of this study. We measured visual acuity via EDTRS charts, and we measured mean differential light threshold with microperimetry. And these data were evaluated at the Vienna Reading Center, so not by us. And as I said, all these outcome variables were assessed during all visits. Now, the inclusion criteria were, of course, the willingness to participate in the study. And as I said, it was not easy to recruit these patients because on the one hand, it turned out to be difficult to find patients with AMD that were not on supplements. On the other hand, if we found patients that were not on supplements, they were often not willing to participate and take supplements as part of the study. So the recruitment was a tough one. We included eyes with AREDS categories 2, 3, and 4, and I will show you the distribution a little bit later. The age was between 50 and 90 years. The patients had to have clear ocular media except cataract, and the visual acuity had to be better than 20/50. We also included patients that had primary retinal pigment epithelium atrophy of more than 125 micrometers, and that had either moderate or severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. In addition, we did not include patients that participated in a clinical trial in the 3 weeks preceding the study. Ocular surgery within the last 6 months was an exclusion criterion, and the history of treatment with photosensitizing drugs. Now, you know that microperimetry is now used for approximately 25 years, and basically the whole story started with the Rodenstock SLO, where the microperimetry was implemented in the late 1970s, early 1980s. But as you all know, the Rodenstock SLO is not on the market anymore. And we used the NIDEC microperimeter, as you can see it here. So you have a fundus view and stimulate the region around the macula with a static perimetry. This is a classical threshold perimetry. Now, the NIDEC system does not use an SLO, but uses an infrared fundus camera for illumination and visualization of the fundus. But the big advantage over the Rodenstock SLO is that the NIDEC offers an eye tracker. And this was always very tricky with the Rodenstock SLO, that if subjects had problems with fixation, it was extremely difficult to record these maps. And this is much improved with the NIDEC system. And we have also shown in previous studies that the reproducibility you obtain with these techniques, at least in early AMD, it's pretty acceptable. It's much tougher in late AMD, but maybe also clinically less relevant. As I said before, the system we used for fundus reflectometry, this was entirely based on the previous work of the Maastricht group. So this is basically a model of light propagation in ocular tissues that was published in 1996. And based on this, a reflectometer was built. Most of you will certainly be aware of this work. Basically, this is from the 2002 publication of the Maastricht group. We basically copied the system. You have here in the pupil plane, this is the entrance pupil, and this is the bar-like exit pupil in the eye. And here you have at this ophthalmological mirror, you have a conjugate plane of the pupil. And here you have the hole in the center. This omits that the corneal reflection is going to the CCD. And the area you illuminate in the retinal plane is approximately 2.8 degrees. And the field that you sample is approximately 1.9 to 2 degrees in this setup. You can also see that you have here a video camera. And this allows for inspection of both the retinal and the pupil plane in order to allow for adequate adjustment and to ensure also the focusing of the beam. what is important is the fact that you have approximately 1.9 degrees. This is the average that you get, and you have a larger field that is in fact illuminated at the retina. The system is tricky if you have people that do not have macular fixation, but in all the patients that we had, as I said, they had a visual acuity of better than 20/50. This is not, in those patients, this is not a major problem. And I will later on also show you reproducibility data that we obtained. What is also important to notice is that, in fact, it's here the conjugate pupil plane that is imaged here. Now, as I said, this is a measurement of foveal spectral reflectance versus position on a horizontal section of the pupil plane. The spectrograph uses a spectral range of 420 to 790 nanometer, and there is a model analysis of the spectra provides macular pigment optical density. Of course, this model analysis also you gain other parameters included. You can also, with this system, investigate the directionality of the reflexes, but we only looked into macular pigment optical density in this study. Now, this is the reproducibility data that we got. This is reproducibility data in healthy subjects, and this is reproducibility data in patients with AMD. This is Plan-Altman plots, and you can see over here, this is a pretty large scale over here, that the reproducibility is pretty good. You can also see that at the 2 sessions, there is on average almost no deviation from 0. This is in fact with very good accordance with what has been published from the Maastricht group. Here you have a different scale. That's the reason why it looks differently. But in principle, it looks pretty well. One thing that is striking, and I will come back to this a little bit later, is that generally on average we got values that were a little bit lower than those from the Netherlands. This is the characteristics of the 126 patients that were included. You can see they were on average 72 years approximately. This is the male to female ratio. This is the RH staging, so most of the patients were in RH2, but we also had a significant proportion of RH4 patients including, meaning that they had advanced AMD in the fellow eye. The macular pigment optical density at baseline was 0.35, and this is indeed lower as what has been published by the group from the Netherlands. Here I would like to mention 2 things. On the one hand, we were very careful in only including patients that did not take any supplements. This could be one of the reasons. And on the other hand, what is also interesting is, and this supports it, is that the standard deviation of results at baseline was lower than in the other studies. So also lower than in the studies from the Netherlands. So we were missing basically patients with higher macular pigment optical densities. This is the light threshold as obtained with microperimetry. This is the visual acuity, and these are the hemodynamic parameters, and finally the intraocular pressure. Now, in one subject, we were not able to obtain measurements of macular pigment optical density at baseline. We do not know exactly the reason, but this subject was excluded, and 9 additional subjects only appeared at the baseline visit, and these patients were not included in the analysis. We lost some patients during the follow-up, and 5 patients were lost to follow-up after 1 month, and 5 patients after 3 months. We had 2 serious adverse events in the lutein group. One was a myocardial infarction, and the other one was a development of a CNV in the study eye. In the placebo group, we lost 2 patients for follow-up after 1 month and 4 patients after 3 months. We had one serious adverse event. This was again a CNV developed in the study eyes. Both of the patients that developed the CNV during the study were RH4 category patients. It's very well known that these patients have an extremely high risk to develop a CNV in the fellow eye. And in all those patients, the last observations were carried forward. Now, this is the main result of the study. Again, you can see here that we had a macular pigment optical density of about 0.35. This was comparable between the two groups at baseline. You can see that we have a pronounced increase in macular pigment optical density that was present already at 1 month and lasted until month 6. With a continuous increase. What is interesting is two things. On the one hand, here we reduced from 20 milligram to 10 milligram, but we still got an increase in macular pigment optical density. The second thing that is striking when you compare it to other studies is the large amount of increase that we got here. We got an increase that it was in the order of 30%. Maybe this is also related to the low baseline values that we had, and I will show you some evidence for this. This is mean differential light threshold and visual acuity. We saw a tendency towards increase with both of them, but none of these results reached statistical significance. What we also observed is that the lower the macular pigment optical density at baseline, the higher was the increase in macular pigment optical density after 6 months of supplementation. This graph, of course, only includes those patients that were in the lutein group and not the patients that were in the placebo group. What is also interesting is that the increase in both visual acuity and macular sensitivity was correlated with the increase in macular pigment optical density, meaning that there was only those patients who had a large increase in macular pigment optical density during lutein supplementation. They also showed an increase in either macular function or visual acuity. This is the increase in macular pigment optical density according to the stages of AMD. This was a post-hoc analysis and did not turn out to be significant. So there was a tendency towards increase in the RH3 group, but this was far from being significant and certainly not clinically relevant. So in conclusion, the study indicates that a 6-month lutein supplementation increased macular pigment optical density in all stages of AMD. We did not observe a change in visual acuity or macular function in patients with AMD, although a tendency was seen. The lower the baseline macular pigment optical density, the higher was the increase in macular pigment optical density after 6 months of lutein intake. And those patients that had the highest increase in macular pigment ocular density also showed the most benefit in both macular function and visual acuity. Thank you very much for your attention.
Okay, thank you very much. We now have time for questions. Yes, we have one from Toss.
Yeah, we saw similar results in an increase in visual acuity, and which goes along with an increase in macular pigment optical density. As Billy Hammond yesterday asked me, how about this visual acuity increase? Can you give an explanation? I cannot. Maybe can you comment on this?
No, I think what is interesting, I don't have an explanation for it. What is interesting is that we saw the same tendency in visual function, in macular function. This indicates that it is not just a blue filter effect, because otherwise you would not see it. The blue filter effect you would not see in macular function. It could be that it is it could of course be that it is related to antioxidative properties. Could be that it is related to anti-inflammatory properties. We definitely don't know. It would have been interesting, but unfortunately we don't have the data to also look, for instance, into macular thickness with OCT. But with the newer OCT system, you might have a chance to find something here, whether you see a reduction in macular thickness. At the time we did this study, we still started with time domain OCT, and the sensitivity of the time domain OCT is definitely not good enough to answer this question. But this could be one reason and one interesting thing to look at. But I think what is interesting is that this tendency is not only found in visual acuity, but it's also found in an sort of a more objective measurement like microperimetry.
Question here.
Did you measure the LMZ0 levels?
No.
Why did you not do that?
Because we didn't have funding for it.
Okay.
We still have the plasma samples, but we could not yet convince the company to do the analysis. This is a very small company that does not have major business, one must also say, in this company.
Okay. More questions? Yes.
Did you assess in any way subjective report in terms of patient report? Do you use any questionnaires to?
No.
No.
With your reflectometry technique, do you see any in the more advanced stages of AMD, do you see abnormalities in the spectrum? Do you worry about artifacts being introduced when there's geographic atrophy, other pigment abnormalities?
No. As I said, in the study eyes, all of these patients had moderate AMD. We did not include any patients with CNV or larger atrophy. And if there was atrophy present, it was outside the region where we measured.
Okay.
So
even drusen, did they cause any problems?
Also, with respect to the drusen, we did not have patients that had so central drusen. But I would agree that in patients, for instance, with advanced AMD, you would see problems, and by chance as I said, we had 2 patients that developed CNV, and we measured in the patients that got CNV, and there you get a completely different spectrum. But this was only the 2 patients that developed CNV, and they came for an emergency visit. But I would generally say that if this is the case, then it would be very difficult to extract macular pigment optical density.